Got in the act, Sophie, drinking.
Sorry.
Good evening, everyone. Neurology, Facebook Live. So nice again to see so many of you joining us from all corners of the world. We've got quite a few people from South America. We have not only one, but two speakers tonight with Sophie Martin and Tom Harcourt-Brown. Sophie and Tom are working at Langford Referral Hospital with the Referral Hospital for the University of Bristol Veterinary School. Tom is the head of neurology, and Sophie is an extremely brave final year resident who has accepted to put herself on the spot, and I think it should be commended, for that, and especially because we're going to discuss a fairly, I would say, controversial subject, which is when should we do surgery? Should we do the surgery as soon as possible, or is it okay to wait? And as you're going to see, it is a very common question. I think as clinicians, we've all been asked that question by the referring vet, by the owner, is it okay to wait tomorrow? Is not an easy question to answer. And very good job on Tom and Sophie to actually try to answer that question through their paper. As usual, we've got our mascot, Simon Platt, joining us from the US. Simon, are you still locked down?
Still locked down, still growing the hair like you. I see that Tom has outdone us with his hairstyle.
They haven't let you go out yet on bail. If you stay from any high school,
still got the ankle bracelet on.
Okay.
They say
I'm sure at some point they will let you out.
They say I can't meet people because of the virus, but I'm getting to think there's something else. There's another reason.
We'll try on compassionate grind next time. I'm sure it will work. Sophie and Tom, welcome, and thanks for giving up your evening. I hope it will be a pleasant experience. I leave you in the hand of Simon. So as usual, Simon will ask you a number of questions about this paper. And then I will invite any one of you listening to put your comment and your question for Sophie and Tom. And I will ask this question at the end of Sophie and Tom's presentation. So over to you, Simon, and over to you to put your question.
Yeah, thanks very much, Laurent. And thanks again, Sophie and Tom, for giving up your time to do this and come and help us with this article. Yeah, very important topic. As Laurent says, brave for sure, because this needs to be addressed. My final question will be: Can you just confirm to me I don't need to get up at 2 a.m. but to do surgery? But let's start off with the first question, which was what was the background for your research? What's the reason for doing it? And can you bring everyone up to speed with what we knew about the effect of timing on prognosis prior to your work?
Yeah, of course. I'll just see if I can share this PowerPoint with you quickly so you can have a look. Does that work okay? Yeah.
Looks good. Coming up. Great. Excellent.
Yeah, so to answer your question regarding the background, so there's absolutely loads of papers that look into this topic in terms of what factors might have a role on when we should operate or prognostic indicators for recovery. So I definitely couldn't do them all justice, sadly. So I've kind of picked 3 papers that I think describe quite nicely maybe how our opinion has changed over time. So the first one's a bit of a throwback to the 1980s. So this is a vet surge paper by Gambardella, who performed dorsal decompressive laminectomies for dogs with disc disease. And he in this paper did evaluate the prognostic influence of how long they'd been off their legs before surgery. But really the kind of quite interesting thing, which I think describes the attitude at the time, was the text that I've just pulled down here from the paper, whereby he says that there was a common opinion that actually if dogs had been off their legs for more than 36 hours, then their prognosis was done and actually surgery was pointless. And he goes as far to say that referring vets in the area were almost trained already to not bother to refer dogs who'd been off their legs for more than 24 hours, and they were just euthanized, because that's how urgent we really believed surgery was at that stage. And clearly we've come a bit of a way and changed our opinion since then. So the second paper, just to touch on, is this one. So this was a JSAP paper from 2016 by Moore and colleagues, and they evaluated the practice patterns and management of disc herniation. So it was quite a cool study. So what she did was distribute surveys to American boarded surgeons and neurologists and ask them various questions about their attitudes to dogs with disc disease. So I've pulled up these 3 pie charts really. So from the questionnaire, the general consensus was that people were fairly in agreement that non-ambulatory dogs were at least surgical candidates. But then she did ask people on their attitudes towards surgery depending on different grades of dogs. So we've got 3 pie charts here from the paper. The left 2 are the same population as our study, and then the right is deep pain negative dogs. So we go from non-ambulatory paraparesis right through to being deep pain negative. And the interesting responses are the dark blue and the red responses. So on the left-hand side, you can see that the red answer seems to make up the majority of the response for non-ambulatory paraparetic and paraplegic dogs. And that response is that the surgery was viewed with some urgency, but within a certain time cutoff, i.e. those dogs had surgery, but within working hours. Whereas on the far right, deep pain negative dogs, you can see the dark blue response is much more common for deep pain negative dogs. And that response is whereby deep pain negative dogs underwent surgery as soon as possible, regardless of the time of day. So to kind of put together a statement that summarised the clearly not 100% majority, but overall majority at that time, everyone is in agreement that non-ambulatory dogs would benefit from surgery. And if they were unable to walk but had pain, we would operate with some sense of urgency, but overall when convenient. Whereas deep pain negative dogs, we operated on ASAP was the kind of consensus at the time. Then the last study, which is probably the best data we have to date looking at this was a prospective study by Nick Jeffrey and colleagues published in JAVMA also in 2016. And they evaluated factors associated with recovery from paraplegia, so deep pain negative dogs with disc disease. And they looked at various factors and found very little to be statistically significant. And the data that I've pulled here is they looked at the delay between dogs becoming unable to walk and then referral evaluation. And really interestingly, they found that a delay of up to 48 hours actually had no statistical significance on who recovered. So that paper went down pretty well and was quite popular with us. So the statement then changed considerably. So suddenly these deep pain negative dogs even became less of an emergency. And again, they fell into that when convenient category. So suddenly hemilaminectomies out of hours became a lot less common. So then just for us as a practice, I guess, what warranted us to do this study was the clinical problem. So we saw in dogs who were either non-ambulatory, paraparetic or paraplegic with pain. And some dogs would have had surgery the same day and then the next day, sadly, were deep pain negative. And then we had some dogs that we saw in that were the same grade, and overnight before we could operate, they were then deep pain negative the following morning. And there's one dog in particular that was stuck in our minds who came in with really good movement, didn't have surgery till the next day, and then was deep pain negative beforehand and just never recovered. And I think the question mark for us was, or for me was, kind of how guilty did I feel about this in terms of, was this deterioration inevitable, or us delaying the surgery, did we somehow do a detriment and actually worsen their injury somehow? So that's kind of what bore the study.
Perfect. Right. Well, thanks for that springboard and the nod to the 1980s, something that Laurent will appreciate there, being the oldest of us all. So in your study then, what were your aims and hypothesis?
Yes. So the hypothesis, so we anticipated that actually the timing of surgery was irrelevant, i.e. the deterioration would be irrespective of when we operated. Therefore, if we analyse these dogs, we hope to find that the proportion of deterioration would be the same in those dogs that either had same day or an overnight delay. So our aims from the study are, we tried to almost do an audit of what we've done already to evaluate, well, this is what we did and what change did that have. And we tried to look at it in a slightly different way. So a lot of the studies and the ones I've mentioned before focused a lot on factors before the dogs were referred, so at home or at the local vets, which we do have some control over, but very limited. So we tried to focus more on, from the point of kind of coming through our doors, what we could change. So we aimed to retrospectively analyse and compare those dogs undergoing either same day or delayed surgery. And the primary outcome measure was to analyse the proportion of dogs that deteriorated in both of those groups. And then the secondary outcome measure was to look at, of the dogs that became deep pain negative, what was their eventual outcome. So those are the kind of aims, really.
Great. Yeah, and so well acknowledged that putting these studies with disc disease dogs together is a really tough job. So how did you design the study to try and achieve those aims and hypothesis?
So in terms of design, we were granted ethical approval by the ethics board at the University of Bristol, and we looked retrospectively over a 4-year period, so through from 2015 to 2018. And we tried to make sure that we included essentially surgical candidates, so dogs that couldn't walk but had pain sensation, and they had to undergo disc disease between T3 and L3, and that had to be confirmed by either CT or MR. And they all had to have surgery within 48 hours. And then we just excluded any dogs whereby their neurological grade for the first 48 hours after presentation wasn't very clear, so they were excluded. And then to form these two groups, so we defined either an early or a delayed surgery group. So early surgery was dogs who underwent spinal decompression between admission, which we called day 0, and then the following morning neuro exam, which we called day 1. And then delayed surgery were the dogs that had an overnight delay. So that meant that between day 0 and the morning of day 1, they had no surgery. And just to put it in a bit more of a graphical way, so we had these non-ambulatory pain positive dogs split between these two groups, and the primary outcome was to evaluate who deteriorated of those two groups and compare that statistically. And then the secondary outcome was, of those dogs who deteriorated, we measured recovery as who recovered deep pain perception at 3 weeks, just because we found that data was much more readily available and reliable. And we just described really the proportion that didn't recover.
All right, so then tell us about the results that you came up with. I know it's going to be it's difficult to tell us it simply, I think, because you've got a lot of stratification going on. But let us know what you found.
Okay, so just to describe a bit the population. So in the end, we had 273 dogs that fell into these criteria, and just to describe them, so they were just under 6 years for the median age, and unsurprisingly, so chondrodystrophic breeds were quite heavily represented, so miniature dachshunds were by far and large the majority of dogs. And in terms of site of disc extrusion, so T12, T13 was the most common site of extrusion that we found. We also had a little look to describe better the two groups. Really, we wanted to, as best as we can, check whether the delay of surgery was the only real difference and that they weren't otherwise handled differently within the hospital. So we initially looked at the time that they couldn't walk before referral and the duration of hospitalisation. And then actually, when we submitted the paper, the reviewers had some really helpful comments about looking more at surgical factors too. So then we went back and collected information about how long the surgery and anaesthetic was, and also how many of the surgeries were performed by residents versus faculty. And overall, just eyeballing those numbers, they're very similar. So that's some data we collected. And then to look at who deteriorated, so we had 273 dogs and split into the two groups. That meant we had 151 in the early group and 122 in the delayed group. So of the early group, we had 7 of 151 dogs that deteriorated, which works out about 5%. And then delayed group, we had 15 of 122 dogs that deteriorated, so about 12%. So what we did with that information is we compared, just to highlight, these two proportions of the dogs that deteriorated, and we performed the two-tailed fishes and actually found that these numbers were significant with a p-value of 0.025. And we also did a number needed to treat analysis. And it's a bit funny to get your head around, but basically that means, so the result was 14, and the idea of that means that if we operated on 14 dogs on the same day, we predicted that we'd have stopped one dog from deteriorating. However, important to note that the confidence interval for that number was quite large, so it ranged anywhere between 7 to 106 dogs. And then the secondary outcome was of those dogs who deteriorated, what happened to them. So of the early group, we found that 5 of the 7 dogs who deteriorated to lose deep pain by 3 weeks had recovered pain perceptions. That's about 70%. And then of the delayed surgery group, of the 15 dogs, sadly, 1 dog developed ascending and descending myelomalacia, so was euthanized prior to the 3-week mark. So then of 14 dogs, we had 8 of 14 that recovered, so about 57% recovery. So the sort of key results, I guess, just to summarize that a bit better, is we did find a significance in the proportion of dogs that deteriorated with an overnight delay. So our hypothesis we had to reject. Of the dogs that deteriorated to lose pain, we only described them just because the numbers were so small, but just comparing percentages, fewer went on to recover in the delayed group compared to the early group. And interestingly as well, if we looked at who then improved by day 1, the early surgery group had a higher number of dogs improving compared to the delayed group. So trying to speculate why that might have happened. So the results in our institution certainly are suggestive that delayed decompression somehow may have contributed to an ongoing injury. And the key kind of explanations that we had for why this might have happened is, 1, whether these dogs actually extruded more disc material, or whether the decompression does help somehow any ongoing ischemic injury, or whether this is actually just a spurious result and something we just happen to find in our population.
Okay, obviously a really important topic here, and what you've done now is create this great springboard sort of for the future. And in your paper, you've made some recommendations of where you would suggest we should go in the future. So, do you want to highlight for everyone listening what you think the limitations of your study are, and then what you would have done differently, or where you actually want to take this?
Yeah, of course. So there's definitely some limitations, absolutely, with our data. And I think the biggest one, inevitably, is that this study's retrospective. So what that means is the dogs weren't randomly allocated between the groups, which ideally is what you would have done. So that just opens up that there is going to be a potential for bias. And are these 2 groups truly the same? And certainly there are loads of factors that I think could have influenced when dogs came in as to what group they fell into. So factors such as what time of day they first went off their legs, how far away they were from the practice, whether they were insured. There's loads of variables that I think would have an influence on as well which group they fell into. But hopefully, thinking about this, those factors would have affected both the same day or the early group and the delayed group equally, but there's definitely scope for bias because they weren't randomized. I think another limitation, or certainly a difference in approach that we had that maybe would differ for other people, is we tried really not to perform too much in the way of statistics. 1, because if anything, we were trying to achieve a bit in the way of clinical reasoning, and it was more of an audit. So we just had one question that we really wanted to analyse. And we tried to avoid the temptation to do loads of logistical regression and generate loads of odds, which actually clinically we didn't know what to do with. So I think certainly that's some big limitations from our paper. I think that in terms of what we would do differently, so definitely prospective studies are always going to be better and stronger than retrospective. But then having a think about how we would actually conduct that is actually quite challenging. So looking into this, there's actually studies that I've pulled up here in human medicine just discussing how difficult it is for surgical interventions to do good randomized control trials. And these discuss how actually in human medicine, there's very little really good quality data regarding surgical interventions because ethically it's so difficult to conduct these studies. So therefore, I'd say that sort of the next best thing with what we can do is to repeat this study with more dogs and at different institutions as well. So to do a multi-center retrospective study. And with the data that we had, we tried to generate a power calculation. So we found that to detect that same percentage difference that we've got here, you would need 246 dogs in each group. So a significantly larger number of dogs than we have already, to basically challenge our findings and see if it's reproducible elsewhere. I think the other thing I just wanted to flag up here as well is a consideration from what we found, because taken at sort of face value, this paper is suggestive, or certainly raises the question about whether we should be operating on more dogs on the same day. And I think the thing that we really wanted to emphasise, that we've discussed in the paper as well, is just the knock-on effect of that. Like you mentioned, getting up at 2 a.m. To do a hemi, suddenly there's other considerations with that, and the main ones for us are operating out of hours is known to generate increased complication rate, increased use of resources, and a more fatigued team. So I certainly just think that that really bears in mind and consideration for potentially what we do next and where we go from here.
Right, thank you very much. Yeah, I mean, as you say, like prospective would be great, but you did a great job like comparing the two groups. Even though they were retrospective, there was great similarity between those groups, particularly with the duration of neuroscience, which I find quite surprising. You'd think there would be some bias, but it wasn't. So that was great. So finally, then, what is the take-home message and recommendations for the people listening to us right now?
Yes. So. Actually, it's more of a question, which is a bit annoying, isn't it? But so we certainly found in our population that an overnight delay may be associated with a greater number of dogs losing pain perception. And if we go back to our number needed to treat analysis, operating our dogs on the same day may have an effect on anywhere between 7 and over 100 dogs. So I think consideration is kind of our attitudes to risk. And certainly I think our take-home message for what we found is that there does seem to be some effect in what we're doing even after the dogs are referred to us. And we may have some control over what happens to these dogs. So if anything, annoyingly, it's a bit more of a question than an answer, but a question as to challenge what we've done before and say, well, should we be operating on more dogs on the same day?
Great. Well, thank you very much for reviewing your study for everybody listening. A really important topic, as has been said, and a tough one to grapple. But I think you've done a great job there. And yeah, okay, we always end up with questions at the end of these studies, but I think that really gives us pause to think. But so thank you very much, and thank you for giving up your time as well to do this. I'm going to hand back to Laurent right now and see if we've got any questions to give to the both of you.
Yeah, we've got obviously quite a lot of questions. As someone say, it's a very difficult, topic. There is no doubt, and I think, as I say, you should be commended for having tried to tackle it. But you and I had a discussion a couple of days ago. What makes a good study is when you as the author, you're able to criticize yourself and look at what you could have done better. So I think we all agree we should not take any study, yours included, the result for granted. You look at it critically, you look at the implication it could have. I think it would be interesting, it's nothing scientific, but it'd be interesting to see as a group of surgeons, if it was your own dog, will you wait the next day? I think that would be a nice little question to ask, and I'm pretty sure most of us will probably do it the same day, if it was your own pet, without a doubt. So quite a few questions. The first one, what was the cutoff for same day? Any impression how quickly the delay could get to the operating room on day one?
Fine. So we didn't have a specific time cutoff. So it depends, obviously, over 4 years. There's a bit of a variation on the working day. So as a hospital, we don't have a set threshold that we stop surgery at the specific hour. So certainly it's hard to know exactly the hours for the cutoff. In terms of how quickly they get to the operating room. So I've got, so we had this question already, so I could give you this data we actually collected since. So this is the delay between the consult and when the surgery started, which I think is useful to know for a lot of people. So we then, because we had this question, people wanted more understandably objective values. So we looked at the delay between the time of consultation and the start time of surgery. So for the early group, the median delay was 3 hours and the range of 1 to 8 hours, and the delayed group, the median delay was 21 hours with a range of 15 to 44. So I don't know if that goes to help answer that question.
But I should ask, I know that, a lot of people had question about, the timing and, if a dog arrive in the morning versus a dog arrive at 5. But I think this should be taken out because you're trying to answer a question, which, you try to do via your study, which is someone, a referring vet asks you, are you going to cut it today? Or the owner asks you that question, are you going to cut it today? Regardless of if it was the morning or the evening, that's what you're trying to answer, as opposed to have, a timing from the time is admitted to the time of the surgery. So you're trying to really answer a practical question as opposed to look at, the exact duration. And I know that that's a question that has come quite a lot. There is quite a few, let me see. Did you notice a difference in the group in function of the visual aspect of the spinal cord during surgery and the difference between the apparition of I don't know what is the other.
Difference in function of visual. Do you want to jump in, Tom? I'm happy.
Crystal, we didn't probably record that data actually. So it might be that there was a difference. I wonder if you're it looks like there's quite a renewed interest in whether the spinal cord there's certainly been a couple of papers recently on long gyrotomies about this. The spinal cord might influence it, and then there's some research to say that the appearance doesn't mean anything about whether a dog's going to recover or not. But it just wasn't one of the factors it wasn't one of the factors that we recorded, we've seen and looked at. So yeah, we didn't have anything more. Sorry.
Just trying to mic.
Really muffled now.
If you can hear me?
Yeah, we can. Your feedback's gone.
We've got one of my favorite neurologists, Rick, but obviously congratulate you on doing this study. I think it's more, a comment rather than question. But I think Rick make a very important point, which is, when you got a disc herniation, there is the compression, but there is also the velocity and the duration, of that compression. And as a neurologist, we can, act on the duration of the compression, and that's the reason why and the rationale for doing the surgery sooner than later. And I think, Rick is perfectly fine. I'm trying to convince, I'm sure he's listening, Rick, to do a presentation for us. So I'm not going to force him, but, if you want Rick to do the presentation, put a lot of comment to invite him and maybe he will say yes. So Rick, again, the offer is there, but we really love to have you, to talk to us and share your tremendous experience.
Can I pick up on Rick's point there?
Yeah.
Is that okay? So Rick, hi. I'm not sure I agree with what you wrote there, unfortunately. That would be I think that one of the things I found really hard with this study was looking back at all the old papers about duration of clinical signs, particularly duration of loss of ability to walk. As far as I could find, 29 different studies looking at that question of the duration of signs, and none of them found an influence of the duration of inability to walk before surgery and the outcome after. Now, most of these were deep pain negative dogs, as you probably well know, Rick. But and there's an interesting systematic review that was published recently about the preclinical evidence, which suggests that the duration doesn't make any difference either, until it's combined with the pressure that's placed on the spinal cord as well. So at different pressures, the duration has a big effect, but duration on its own doesn't seem to have a very big effect. And wonder whether the evidence taken together suggests that removing compression at any point makes very much difference at all. The evidence doesn't really show. It may show there's a window of a few hours, but that after that it stops being a very big influence. And so the really interesting bit I found about the paper was this dichotomy that animals can be off their legs for as long as they want to be at home and it doesn't influence their recovery. But we've sort of maybe found that as soon as they come in, you've got to operate urgently. So I wondered whether actually the main benefit to our surgery is not removing the compression, but it might be preventing more compression happening. And I wonder if these small numbers that we saw are dogs that extrude more disc material. And maybe with a cord that's already damaged and compressed, more material is catastrophic. And so it might not be that decompression is the main thing to be doing to these dogs. It might be perhaps that fenestration or making more room for more disc material is the important thing. And that kind of goes hand in hand with the work that Paul Freeman did recently, looking at fenestration alone, where he was looking at the fact that fenestration surgery seemed to have a really good result in non-ambulatory dogs. There was no decompression performed from some of the older studies. So that was my take home, really, was that maybe it's the stopping more disc material coming out that's the big argument. So I don't know that decompression. We came to this study largely with the idea that I wondered how useful surgery actually was, to be honest with you. And so the bias of leaving dogs or maybe operating on worse dogs, I was sort of the view that maybe surgery isn't actually that important. So I was really surprised to find that it was. I know that's not a typical view amongst neurosurgeons, but yeah, I hope you don't mind me arguing with you, Rick, without any ability for you to come back. But I hope you'll let me know if you disagree more.
I'll make sure I post this comment. The next one is, did you consider if the treatment before surgery could interfere with the prognosis? I think you briefly mentioned that.
Yeah, I think so. And I think in terms of treatment, I guess the biggest one we have looked at previously is the use, I guess, of steroids before surgery and factors like that. So certainly, obviously, it's difficult in terms of what was given prior to referral. Again, what we don't necessarily have control over, but certainly the dogs in this population, in terms of their medical management, they were all very similar around the time of surgery. So I think, I think that certainly the treatment before surgery is limited in terms of just rest. And another reason why we were keen to look at the dogs after the point they'd arrived with us is actually that, we had much more control. So we knew those dogs were truly crate rested and had the same degree of medical management. So certainly I think that's a very interesting point to have raised.
We run out of time soon, so I'm going to take two more questions. One from a young neurologist as well, Cohen from Holland. What about the influence of anesthesia for the diagnosis and the delay after that? Would that influence perfusion by any chance and might have influenced grade 4 becoming grade 5, especially after delay?
Sorry, Sophie, you go.
Thomas, fine, go.
I was going to say this seems to be a thing that people are looking at more, kind of, and I wonder if it's something that you're looking at then if you're a resident that Laurent's recognised. But there's a couple of studies, aren't there, about the duration of anaesthesia maybe not playing a big role in it. We didn't, as Sophie presented in our table, we felt that there wasn't really any difference in the duration of anaesthesia or surgery between these two groups. It looked very much to us like the figures were very, very similar. Now it may be that there was more of an influence, and this idea that particularly in MRI where you can't monitor their anaesthesia quite as well as maybe you would like because of the challenge in your monitor equipment, maybe it has a big influence, or even just moving dogs under anaesthetic and allowing more discs to come out could have an influence. But yeah, again, unfortunately, it just wasn't something we felt that retrospectively we could get any solid data on. So we've chose not to really even include it because the data wasn't going to be reliable and wasn't our primary question.
Apology if we can't take any more questions. Obviously, we don't want to drag too long. I'm sure Sophie and Tom want to do something else of their day as well. Guy, I can just say thanks a lot for giving up your time. Sophie, I think it's amazing, at your level of your career, that you accept to put yourself, doing this presentation to all of us.
Well,
and also you also feel very confident. Tom, great job in making, achieving a great resident, like Sophie. Again, this type of study is open to a lot of criticism, but that's what it's all about. At the end, we want, I think, in our community to be able to exchange ideas. We don't want to create dogma, certainly. And I think that's, what you've done, and you presented it in a very open and honest way. So I think great job for that. Simon, if you want to give the last word, you'll be very welcome if you're still with us.
I'm still with you. Don't worry. I'm falling into a coma. Yeah. Thanks, Laurent, and echo really what Laurent said. Thanks, Sophie. Tremendous job. Thanks, Tom. Sophie, giving up your time. Really tough subject, as we said now, and so much to tease out with all of that data. And I think the success of any study, any paper that we read, really comes down to: does it make me, or does it make us think how we can do a better job? Does it make us think about what we currently do? And this certainly does. So great job on that point. Thanks very much, and thanks to everyone who's tuned in.
Next week, before we go, we've got a neuroimaging session. Our vetorical radiologist, our queen of MRI, Ines Carrera, will be doing a review on cystic malformation of the caudal fossa. So I will invite you all to listen to a presentation. She's an amazing lecturer, but also an amazing teacher. We'll do that presentation not on a Thursday, but on Wednesday. I think it's a day already. We do it on Wednesday, not on Thursday. But again, we will advertise on our Facebook and Instagram. Thank you very much, Sophie and Tom. If you want to say anything, you're very welcome. If you want to escape, please do. But
just say thank you, Laurent and Simon, for giving us the opportunity to talk about it. Yeah, it's a great format, this. So
and if any one of you listening want also to put themselves on the spot, you're very welcome. So you can contact us. If you publish something recently, you're very welcome. I think it's a good model to do that, and it's probably more friendly model than a congress and so on. Thank you, everyone. Have a good evening. Bye-bye.
All right. Bye-bye.
Bye.